Hello, everyone, and welcome to the first Brian Grant Foundation Wellness Webcast of 2024, sponsored by Kiowa Kieran and Amneal. I hope everyone had a wonderful new year and are doing well. I want to thank you for taking the time to join us today. We're going to start off the year with going back to the basics, doing an overview of Parkinson's, talking about everything from diagnosis to treatment. I want to invite you to ask questions in the chat box below, and I'll do my best to get to them after the presentation. I'd like to welcome our presenter today, Dr. Joseph Quinn, the director of OHSU Parkinson's Center and Movement Disorder Program in Portland, Oregon. Welcome, Dr. Quinn, and thank you for joining us. At this point, I'm just going to hand it over to you and your presentation.
Wonderful. Thanks, Amy. Thank you for the invitation to do this, and thanks for that nice introduction. Are you seeing my screen okay? Can you see my slides okay?
Yes, I can see them.
Okay, great. All right, well, you just heard what I'm going to talk about. So it's an introduction to Parkinson's. Shoot, what's going on here? Okay, here we go. So we'll start off by talking a little bit about how a diagnosis of Parkinson's is made. And then we'll talk about what we call the motor symptoms. So the motor symptoms are the symptoms that have to do with movement, tremor, slowness, stiffness, that kind of thing, and try to give you an understanding of what underlies them. And then how we treat those symptoms, the movement aspects of Parkinson's, and also talk about how those things change over time. But it turns out that Parkinson's is not limited to symptoms of movement, as I'm sure many people on the call know. And some of the other symptoms we refer to as non-motor symptoms, symptoms of Parkinson's disease that are not movement phenomena per se. And we'll talk about what a patient should do about all of these things. And I think we'll have some time for questions after. And someone is monitoring the chat box as we go, so feel free to put your questions in there. So when we talk about diagnosis, I want to start off by making the point that in medicine in general, we have sort of three prongs for making any diagnosis. And one element is the history. A second element is the physical examination. And then the third element that is sometimes employed is laboratory testing, whether it's blood tests or scans or what have you. And we involve all these things when we're thinking about the possibility of Parkinson's disease in a given patient. So, as you all know from visiting doctors, the first thing that a doctor does is ask you about your symptoms and how they evolved. And when we're asking for the history in somebody in whom Parkinson's may be a possibility, we ask about tremor, we ask about stiffness and slowness. We ask, has your handwriting changed? Handwriting gets smaller with Parkinson's disease. We ask about the person's facial expression. Sometimes it's really a loved one that notices their facial expression has changed as a manifestation of Parkinson's. We ask about voice. Voice gets softer in Parkinson's. And we ask about walking. And, not everybody has all of those symptoms. And even tremor, which a lot of people think of as an essential part of Parkinson's, is absent in a significant proportion of people with Parkinson's. So we want to get a sense of all those things when we're asking about the history. We expect to hear that there's been a gradual onset if it is a condition like Parkinson's. And we also ask about the rest of the history because there are some medications that can mimic Parkinson's, and we want to make sure that those medications are not the cause of somebody's symptoms. So we really are relying on the patient and their family to fill us in on the history, and it's really an essential part of making a diagnosis. The second element is the physical examination, and we actually touch the person and move them around and observe things carefully. We look at if there is a tremor, we look at the tremor, we look at the nature of the tremor. We move the extremities to see if there's rigidity in terms of the muscle tone when the person is trying to relax. And we refer to the type of rigidity that's characteristic of Parkinson's as a sort of cogwheel rigidity, meaning it's kind of a ratchety feeling. It's hard for the patient to see that, but we can see that when we examine the patient. We look for slowness of movement, and the medical term for that is bradykinesia. And we test that by asking people to tap their fingers or to open and close their hand rapidly or to do some other movements. And that's how we assess whether there are physical findings to support that idea. And then lastly, we get people up and walking around, and we look at their walking in some detail. We look at whether they swing their arms. We look at whether they shuffle. We take a very close look at how they turn. So we have them walk down the hall, turn around and come back. And the turns, even sometimes when the rest of the walking looks pretty good, the turns sometimes give us some clues to Parkinsonism. So these really are the mainstays of making the diagnosis, the history and the physical. And when we're done taking the history and physical, and we'll come back to laboratory testing in a few minutes, but when we're done with that, we are typically deciding whether someone has the signs and symptoms of Parkinson's. And at that point, we use a term called Parkinsonism. And you see it's a small p. Parkinson's disease, we use a capital P. Parkinsonism is a little bit different. It's an umbrella term, and it covers a number of conditions, with the most common of which is Parkinson's disease. But there are other conditions that also have the signs and symptoms of Parkinsonism. And the lower left on this figure, you see it says medication-induced Parkinsonism. So that means the person doesn't have Parkinson's disease per se, but they have the symptoms induced by a medication. And in that case, we can usually see some improvement by removing the offending medication. Another entity listed in the left side of the figure is vascular Parkinsonism. Vascular is blood vessels. And this is another mimic of Parkinson's disease that's due to its small strokes that are affecting some of the same brain areas that Parkinson's disease affects. So you get something that looks like Parkinson's disease, but it's really a phenomenon due to small strokes. On the right side of the shaft of the umbrella, there's listed several more complicated names, and these are syndromes that we sometimes refer to as Parkinson's plus syndrome, and that means that people have the movement signs, the motor signs of Parkinson's, but they actually have a degenerative disease which is a little different. And I've listed the names of those diseases there. I won't go through them in any detail, but it's very common for us to initially think that people with those diseases, like I said, we call them Parkinson's plus, as they're listed here. They're also called atypical Parkinsonisms. Our usual experience is that the patient comes in, we think it might be Parkinson's, we put them on the medication for Parkinson's. It's not very helpful. We continue to monitor the patient, and then over months and years, we see some other symptoms appear that tell us it's something a little bit different. So those other entities are less common than Parkinson's disease per se, but if you go to a doctor and the doctor records in the chart or tells you that the diagnosis is Parkinsonism, this is what they're referring to. They're referring to a more general term, and then over time and with some other input, they may become more comfortable with a more definitive diagnosis of Parkinson's disease. You know, sometimes the presentation, the signs and symptoms are so clear-cut that we do make a diagnosis of Parkinson's disease straight away. But I know the use of this term Parkinsonism gets very confusing for folks. So the diagnosis of Parkinsonism is really, it's based on this history and on this physical exam. You don't have to do any tests to confirm the diagnosis. There are some tests that are available, and I'll describe one of them in a few minutes, but none of the tests are part of routine care, and they're reserved for certain circumstances. You know, as I said, a lot of times people will come in and will think right from the get-go, boy, this sure looks like Parkinson's disease. It's really got all the typical signs and symptoms. We put people on the medication for Parkinson's. They have a very good response, and then we're pretty sure about the diagnosis just from that point. And that's a common practice, but it's also supported by lots of research that medication responsiveness is a strong indication of what the diagnosis is. If people don't respond, and if they develop other atypical problems over time, then we may revise the diagnosis to one of these other atypical Parkinson's variants. And again, we'll get to the laboratory test in a moment, but I think it makes more sense to introduce the laboratory test after I go on to our next topic, which is what causes the motor symptoms. Amy, I wonder, have any questions come through about diagnosis that we might take now rather than holding to the end? And I'll
None that have come through yet, no.
Okay. And we can take them later on. I just thought before we move on. All right. So the next bullet that I want to go through is what causes the movement parts of Parkinson's disease, sort of the fundamental parts, and we refer to them. They're about movement. We in neurology usually call them motor symptoms. And the motor symptoms are related to loss of cells that make dopamine. Can you see my arrow on the screen? I don't know if you. So the picture that you're seeing is a side view of the brain, cut right in the middle. And what it's showing with this black arrow, that's where the brain cells are that make dopamine. So they start here in the upper brain stem, and then they project up to this area, and they sprinkle dopamine around there. And what happens in Parkinson's disease is that those dopamine cells are kind of withering and eventually dying. Some of them have died by the time people are diagnosed. And it's this loss of dopamine in this area where they're supposed to be sprinkling it that gives rise to the movement symptoms. And you can see this if you look at the brain in other views. I think maybe I won't go through that in too much detail. But that loss of dopamine neurons, that loss of dopamine brain cells, is really the basis of the treatment of the motor symptoms, and I'll get to that in a minute. But it's also the basis of one of the diagnostic tests that has come into use in the recent past. And this is a type of brain scan that's called a DAT scan, a DAT. So it's not a CAT scan, it's a DAT scan. It's a little different. And the D actually stands for dopamine. So DAT is meant to abbreviate dopamine transporter. And this is a scan that visualizes in a person's brain how healthy the dopamine cells are. And this picture that I'm showing you down here on the left, this is an MRI scan. This is not a DAT scan, but I'm showing you what the brain tissue looks like in a healthy person. And in red, it's outlined where the dopamine cells are sprinkling the dopamine. So this is called the striatum. And this whole red area, when the brain is healthy, the tips of the brain cells are getting there and it's sprinkling dopamine there. So what the scan does is visualize that area. So the rest of the brain is a little fuzzier than in an MRI scan, but in a DAT scan, here, the DAT scan that says normal, you see this red area. That's where the dopamine transporter is. And it looks like two comma-shaped things that are similar to the red part in the MRI scan that I showed you a second ago. So a healthy brain with healthy dopamine cells has a DAT scan that looks like this, that there's lots of dopamine cells getting to that part so you can visualize the dopamine transporter there. In Parkinson's disease, you can see all the red stuff is shrunken down, and it's no longer a comma shape. It's a circle. It's much smaller than you see in the normal scan, and that's showing you the difference between a normal brain and a brain with loss of dopamine cells. So this scan is sometimes used for us to help make the diagnosis. It's not part of standard care. It's not something that everybody needs to have. But it's a scan that we do when we're unsure about the diagnosis for one reason or another. It's been available, I don't know, 7 or 8 years now. So we've got a fair amount of experience with it. It's not a perfect scan, but it is something that is widely available and increasingly used. And I brought it up because some of you have heard about it or will hear about it. Okay.
Question about the DAT scan, real
Yep.
quick. Do you see this being helpful in the future, having a scan at diagnosis and then later on using it to show progression or
that's a great question. The unfortunate fact is that once people have a diagnosis, the scan doesn't change very much over time. And there's a lot of work underway to try to make that work better. There's a lot of work underway to find better ways to visualize those dopamine cells to use just for that purpose. But so far, it's been a little disappointing in terms of monitoring progression over time. But great question. It's something that I have asked myself. Okay. But that sets up nicely, I think, to were there any other questions about that scan or diagnosis, Amy?
I had one more question about diagnosis. Do you see a difference between a young onset and, let's say, a typically presenting person with Parkinson's when it comes to presentation of symptoms or how you're diagnosing them?
No. So the signs and symptoms are the same for young onset as for older onset, and the utility of the DAT scan is the same. The response to medications is the same. There are some other differences in the course sometimes, but at the time of diagnosis, there's not much of a difference.
Okay.
I will
say,
one
more question about a DAT scan. Are they typically covered by insurance?
Yeah, DAT scans usually are. You usually need pre-authorization, but they're usually covered. Yeah. And let me say one other thing that I didn't put in the slides. People wonder about the genetics of Parkinson's disease. And when I've got a book on my shelf here from when I was in training, and it says there is no genetic basis of Parkinson's disease, which was one of the many facts I was taught in medical school that are not true. So it turns out we have identified a number of genetic causes of Parkinson's disease, but they're all very, very rare. And in the general population of people with Parkinson's disease, we only rarely identify a gene. The most common gene among those genes is present in 5% of people with Parkinson's disease. The second most common is present in 1% of people, and the next one after that is less than 1 in 1,000, and they go down from there. So, these the genes are not part of the routine testing for the diagnosis either. They are being done on a research basis for a number of different reasons. But what triggered me to bring that up was the idea of young onset versus old onset. When we see a young onset person, the younger they are, the more we worry about a genetic cause, rather than just a sporadic case. So sometimes genetic testing is done. Okay, so that picture, I hope, of the dopamine cells and that explanation that the dopamine cells are declining in Parkinson's disease sets us up to talk about how we treat the motor symptoms, right? So if we're low on dopamine, we replace the dopamine. That's basically the essence of trying to treat the movement symptoms of Parkinson's disease. There are a few different medicines that are available to do that, but the one that is the most potent is a medication called levodopa. And levodopa is it's a precursor of dopamine, meaning if you give levodopa to a brain cell, it'll turn it into dopamine. It makes it it's a building block for dopamine. So that's how it works. Now, it turns out if you just take levodopa by mouth, your enzymes in your blood and your other organs will break it down and it'll never get into the brain. So a trick was developed going way back to the 70s, wherein levodopa is given in combination with something called carbidopa. Carbidopa blocks the breakdown of levodopa in the bloodstream and then makes the levodopa available to get into the brain. So if you take levodopa without carbidopa, it it gives you side effects because of the breakdown, and it never gets into the brain. So whenever we prescribe levodopa, it's as carbidopa levodopa. So that's why you've got that long name on your pills if you're being prescribed medicine for Parkinson's disease. There's two parts to it. And then you also know on the name, if you're on one of these pills, there's two numbers. There's the first number / the second number. So 25/100 is a common name. The first number is the amount of carbidopa, and the second number is the amount of levodopa. Now, levodopa is the oldest medicine and still the strongest medicine for restoring dopamine function in the brain. But there are other medicines that are sometimes used to treat Parkinson's, and they, I don't think I'm going to get into the details of the choice about which one to use, but these other medicines work not by serving as a building block for dopamine, but by serving as fake dopamine. The brain thinks that these drugs are dopamine. So they're called dopamine agonists. An agonist is something that binds to the receptor of the dopamine. And the two dopamine agonists that are currently in use, the generic names are pramipexole and ropinirole, as I've written in that last bullet point here. And the brand names are Mirapex or Requip. So all these medicines have a role in the treatment of Parkinson's disease. The likelihood of starting with one or the other has varied over the years and continues to vary with the practitioner. But there has been a move in recent years to get back to levodopa. There's a few reasons for thinking that is a preferred initial therapy. That doesn't mean it should be uniformly used. And please don't go to your doctors and say, Dr. Quinn said I have to be on this. But it's the most commonly used one that's out there, and it's the one we start in most cases now. This is just showing you graphically how these two different medicines work. So this top figure that's coming down is one dopamine neuron. So this is the dopamine neuron that's sprinkling the dopamine in that area that was red in those other scans. This is the receiving cell down here on the other side. And what you can see is that there are these little packets. They're little bubbles. They're called vesicles. And those black dots inside there, that's the dopamine. And those little bubbles, those vesicles, go down to the tip of the neuron of the brain cell, and they squirt the dopamine out into the synapse. And then the dopamine gets taken up by the receptor on the other side, and the signaling proceeds. So if you're short on dopamine, you can give levodopa. It goes into the cell, and the levodopa is L-dopa. It gets converted into dopamine and then comes out. On the other hand, if you're being treated with pramipexole or ropinirole, that drug is a dopamine agonist. It's not going through the initial neuron. It's going right to the synapse. And it looks like dopamine, but it's not really dopamine, right? It's fake dopamine, but it binds to the receptors and creates the same signal. So that's how these two different medications work to replace dopamine. So what is, that's a nice cartoon and an explanation, but what do they do for the patients, right? What happens when people get put on the medicines? Well, in typical Parkinson's disease, the medicines really improve the slowness and they improve the stiffness. They also sometimes improve the tremor, but the effect on the tremor is a little less consistent. So some people, they take these medicines and the tremor melts away. Some people take gobs of the medicine, and even though they really have Parkinson's disease, the tremor is a little bit resistant. So that's an important thing to be aware of, that the slowness and stiffness and tremor may not all run together and may not all respond in the same way. And since the tremor is the most visible thing to the patient, they sometimes draw a conclusion about what the medicine is doing purely based on the tremor. It's important to appreciate you might be getting some benefit even if the tremor is not responding. So these are symptomatic medicines. They improve the symptoms, but I'm sorry to say, they don't prevent progression of the disease. Something has started in motion to damage these dopamine neurons. And although the medicines improve the symptoms and improve the symptoms in a durable way, the disease does progress and things change over time. that doesn't mean your medicine stopped working. It means that the underlying disease has progressed, and we need to think about other medications and changes in dosage and that sort of thing. There was also a belief at one time that some of these medicines might accelerate the progression of the disease, that they might make the disease move faster. And there was a belief at one time that we should hold off on these medicines as long as possible. And it turns out that some very good research has put that idea to rest. These medicines do not accelerate the disease progression. So we currently use the medicines to try to optimize a person's function day to day. We don't start it if they don't need it, but we also don't hold off as long as humanly possible. We're trying to treat a person to help them function as best they can. These couple of points about, particularly the last point, that the medicines do not accelerate the disease progression, is something that is very much misunderstood and misrepresented on the internet and so on. So I can't emphasize that enough. These medicines we want to use to help people function, and I hate to see people forego therapy that could be helpful to them in that way. So that's on the plus side. Now, what about on the side effect side? What do we see? Both medicines, the levodopa and the dopamine agonists, sometimes cause some nausea. That can be attenuated by or reduced by taking it with food. You'll often hear that you shouldn't take protein with levodopa. And the reason that the pharmacists tell us that is because protein blocks the absorption of the levodopa. But that doesn't mean you have to take it on an empty stomach. You can take it with non-protein snacks, crackers, yogurt, applesauce, other things that are not rich in protein. And that can sometimes help with the nausea. Typically, starting at a low dose and building up the dose over time helps to minimize the nausea. Sometimes a little extra carbidopa can help with that, and some other medications are sometimes used. So it's not an uncommon side effect, but it's usually something that can be managed over time and that declines on its own over time. Another thing that I warn people about when they start one of these medicines is that these medicines lower your blood pressure a little bit. They don't cause it to bottom out, but they make it a little bit lower. And when you stand up too quickly, when you have that phenomenon, when you stand up too quickly, you get lightheaded. And in the extreme, you could even pass out, although that's pretty rare. But it's something to really watch out for. Sometimes we have to think about adjusting other medicines. For example, if you're on a blood pressure medicine, you've been on blood pressure medicine for a long time, we add levodopa or dopamine agonists, and your blood pressure is unacceptably low. One of the things we can do is just reduce your blood pressure medicine. So we do that in concert with the primary care doctor. But it's another common but very manageable problem. So these two side effects are common to both levodopa and to the dopamine agonists. Now, I want to make a couple of comments about the agonists. So this is pramipexole, also known as Mirapex, and ropinirole, also known as Requip. So one of the things that they do a little more than levodopa is they can promote sleepiness, even to the point of what are referred to as sleep attacks. It's not in everybody, but it is something to be aware of, in terms of driving safety and that sort of thing. So when you start a new medicine like this, keeping an eye out for how sleepy it makes you and whether you have a tendency to fall asleep abruptly. The other thing that happens, and this is also very much in a minority of people, but we've realized that it's an important thing for us to monitor for and adjust our medication if it appears, is a set of things that are described as impulse control disorder. And in this case, in the instance of this entity, people become impulsive spenders, sometimes develop gambling compulsions, sometimes develop sexual compulsions. So some of these things, or eating is the other one. Um, Many of these things are embarrassing enough that people don't bring them to the doctor. So if one of those medicines is started, we make sure that we talk to the patient and the family member about the risks of those things so we can monitor for them closely. It is a minority of people, but in the extreme form, it can be so disruptive that we have become more and more careful about counseling people about this and monitoring for it. All right, so that's just a few words about the initial treatment of the motor symptoms. The next thing I want to describe is, what happens to these motor symptoms over time. So, unfortunately, we're working on it, but we don't have a way to arrest the progression of disease. So, over time, people do have worsening of their movement problems despite the medication. And then we have to take steps to try to treat those motor symptoms more effectively. And this figure here is trying to show that, when you take, these are the carbidopa-levodopa pills, or showing you the levodopa levels in the bloodstream. This up and down curve is showing you what happens in your blood. You take the medicine, the blood level goes up, and then over time the blood level goes down. You take your next dose, the blood level goes up again. And the course from left to right is trying to show you a time scale. And in the beginning, when you're taking your medicine, you're in this white phase of the diagram, which is the phase when the medicine is really doing a good job for you. Your symptoms are very well controlled in this white part. If your blood level gets too high, you sometimes get some wiggly movements that are called dyskinesias. And if your blood level goes too low, sometimes you have a period of time when your motor symptoms are not under control, and we call that off time. And in the beginning, just the way things go with mild and early Parkinson's, people end up spending most of their time in the therapeutic zone, in the white area in the middle. But as time goes on, those two shaded areas, which are the not so good areas, become more and more narrow. And as the blood level goes up and down, people tend to have fluctuations in how they're doing. And we call that phenomena of going up and down, we call it wearing off. And at one end of the blood level, it can be off time. And at the other end of the blood level, it can be involuntary wiggly movements, which are dyskinesia. So when this happens, there's a few things that we can do that are actually quite effective at smoothing this out and trying to give people good quality time during the day. So one obvious thing is you can increase how frequently you give the levodopa, so your blood level is a little more stable. Sometimes if we started a person on levodopa, sometimes adding a dopamine agonist can help to smooth things out, because the agonists just tend to stay in your bloodstream a little longer than the levodopa. There are also medicines that can be added to the levodopa that interfere with the breakdown of the levodopa, and I've listed one of them here. And then the final thing on this list is a form of levodopa that is released much more slowly, so it gives you a more stable blood level. That drug is called Rytary, and this is showing you a picture. It's in capsules, and what you see in the picture is that some of the beads are big and some of the beads are small, and these are all levodopa, but the different size beads give you gradual release of the medicine, because the small beads dissolve and release the dopamine into your levodopa into your bloodstream very quickly. The bigger ones dissolve more slowly, so it takes a long time. I'm not trying to advertise the drug, but it really can help sometimes when we're dealing with fluctuations. The downside is it is more expensive and takes a long time to get pre-approved, and there's often out-of-pocket expenses that are that interfere with that. And then very briefly, I'll just make the point that when people have very advanced disease, and I'm talking about 8 to 10 years from diagnosis, even though that's not a strict number, just as an estimate, it's a decade after diagnosis. Sometimes our oral medications just don't do the job, and then we start to look at therapies that we describe as advanced therapies. One of those therapies is a form of levodopa that gets delivered directly into the intestine. There's a delivery tube placed, and then people plug that tube into a pump, and you can get continuous infusion of the levodopa. And the levodopa goes right to the site in the intestine where it gets absorbed into the bloodstream. So that can give a very stable blood level. It was approved in the United States in 2015. It was approved in Europe before that. And some people have found that to be an effective way to deal with fluctuations. Continues to be available. And then the other treatment that many of you have heard of is called deep brain stimulation. And that's might be thought of as like a pacemaker for the brain. So some electrodes are passed down to the movement centers of the brain, and then the electrode is attached to a generator that sits under your skin on the chest, just like a pacemaker, and can be programmed to optimize how that brain area is functioning. So I didn't want to get into detail on those, but I just wanted to mention those as what we call advanced therapies. Those are the only two advanced therapies that we have right now, but there are other advanced therapies on their way. So in the future, you'll be hearing about some other things that'll be available for people with more advanced Parkinson's disease. Now, everything I've talked about so far has been motor symptoms, movement symptoms. What I want to do in the last few minutes is talk about other symptoms. But Amy, let me see if there's some pressing questions that we might take now before I move on to that section.
Yes, I'll bring up some of the medication questions. One is the carbidopa levodopa. Is it in one pill?
Yeah, it's in one pill. Yes, it is.
And if you miss a dose, does that affect any sort of progression or the disease?
So it does not, missing a dose does not affect the rate of progression. We think, and this is, we think rather than we know with certainty, but we think that by taking your dose more regularly, you're a little less likely to have those fluctuations, that the more smooth your dosing is over time, the more smooth your blood level is, and the less likely you are to have fluctuations.
Is there a generic for Rytary?
There is not yet. Yeah.
And do you know kind of like the timeline on that, or will there one be coming?
Yeah, I don't think there will be. And I mean, I could be wrong, but Rytary is not a different drug. It's a different kind of formulation. And I think it would be pretty hard for another company to come up with a precise formulation like that and get it tested. I hope I'm wrong, but that's my expectation.
Okay. Is it okay to take an extra dose of carbidopa levodopa if you're feeling out of it?
You should ask your doctor about that. So, one of the two big problems with taking an extra dose is if you overshoot, you can get low blood pressure. You can overshoot, you can get dyskinesia. You can overshoot, you can get hallucinations. So when I have individual patients ask me that question, some of them I say go ahead, and some I say, listen, let's not do that because I know they're at higher risk. So that's an individualized answer.
Okay, and this is probably an individualized answer too, but I'll ask it. Are there advantages to starting with Mirapex versus carbidopa levodopa?
That's a great question. There are pros and cons to each one, and one of the pros for starting Mirapex over levodopa is the risk of dyskinesia, of wiggly movements, is lower with Mirapex than with levodopa. But the risk of impulse control disorders and other psychiatric issues and sleep attacks is greater with Mirapex. It's a question that's hotly debated, and the answer has changed over the years. But the recent consensus has really been leaning towards starting with levodopa rather than Mirapex. But there's not a right or wrong answer. It's something that's still debated. Because younger people are going to be at it for the long haul with the disease. That's an instance where some of us prefer to use Mirapex over levodopa as initial therapy. But even that, some years ago, that was the norm. That's a lot of people are starting with levodopa now. And when I say a lot of people, I'm talking about people that are really, national experts, the Mayo Clinic, other places like that. So, but having said that, I probably have a couple of people I've started in the last year. For whatever reason, I've started with Mirapex. So it is an individualized question.
All right. If you get the Duopa, are you then still a candidate for DBS? And what makes you a good candidate for DBS?
Yeah, great question. So the candidates for DBS are people who clearly have Parkinson's disease, clearly have a responsiveness to levodopa. Okay, so it's not something that we use for any of the Parkinson's variants or any of the refractory treatments. It's reserved for people who have not had good symptom control with oral medications. So those are the kind of big general indications for DBS. The contraindications are the things that complicate matters. So if you're a bad surgical candidate for one reason or another, that might be a reason not to have DBS. There's a concern about worsening cognitive function with DBS. So people who have cognitive problems to begin with, we steer away from DBS. So those are, and there's a lot of other finer points, but I think those are the main points that I would say. If you have Duopa as your first advanced therapy, there's no reason you couldn't have DBS at a later date, and even vice versa. But when people are deciding on whether to go with an advanced therapy or not, you're usually making a decision one or the other. I have been amazed. Patients tend to prefer DBS than to having the pump.
Are there any drawbacks to DBS?
Well, there are some. Anytime you have brain surgery, there's risks, right? There's risks of bleeding and infection and those sorts of things. Anesthesia. Those risks are really relatively low. As I said, there's a risk of cognitive worsening. So those are the main risks. But I'll emphasize that the DBS is an approved therapy. It's covered by insurance. It's standard of care now for advanced Parkinson's disease.
Do you have any recommendations for management and impulse control?
Well, first order of business is to try to get people off of dopamine agonists because we think that's the biggest offender. Then we, if people get all the way off of dopamine agonists and they're still having a lot of symptoms in this area, a lot of what has to happen is to control the environment to try to keep them from getting into trouble with spending and gambling and other misbehaviors. There's not aside from getting people off of the agonist, there's not a standard treatment, medication that we point to for impulse control disorder, but we do consult with our experts in psychiatry and try to help with some of those things.
All right, I'm going to ask one more question, then we'll continue with your presentation.
Okay.
Is it okay to skip a dose if you are feeling good in the evening?
It's okay. And again, you should make sure you discuss it with your doctor. There's nothing terrible that happens if you miss a dose. You don't go into withdrawal or anything like that. But there's some some evidence that the smoother we can make the blood level during the day, the better things are kind of in the long term in terms of fluctuations and motor complications.
Okay, thank you. I'll let you continue with the rest of your presentation now.
All right, great. Well, thank you for collecting those questions, and I think that helps to bring them up while they're fresh in everybody's mind. So the last couple of things I want to mention are these last two bullets, and one of them has to do with non-motor symptoms, and I've listed out here some of the symptoms that we've come to recognize are part and parcel of Parkinson's disease. This doesn't mean that everybody gets them, but they really are a feature of Parkinson's disease per se, but they're not things that have to do with movement. So constipation is a big part of Parkinson's disease. I mentioned low blood pressure as a complication of the therapy, but can happen on its own. There's a sleep disorder that is referred to as REM behavior disorder. This is a phenomenon, most of you have heard the idea that REM is rapid eye movement sleep. That's the phase of sleep when you're dreaming, and your brain in a healthy state keeps you paralyzed when you're having a dream, so you don't act out your dream. In some instances of Parkinson's disease, that mechanism in the brain is disturbed, and people go into REM, which is normal. They have a dream, which is normal, but instead of being paralyzed, they act out their dreams, and their bed partner gets beaten up and that kind of thing. They throw things around the room sometimes, can sometimes fall out of bed and get injured. So it's a significant problem that can occur. When people have had Parkinson's for a long time, they'll have some troubles with their thinking abilities. We refer to that as cognitive impairment. There are psychiatric problems like depression and anxiety that are not just a reaction to having a tough disease, but are we think part of the biology of the disease. And then some people develop hallucinations. So there's this long list of symptoms that we neurologists have come to recognize as part of the disease and part of our responsibility for treatment. And the thing that I want to emphasize about these symptoms, everything up to now we've been talking about has been dopamine related, right? And all the therapies have been oriented towards improving dopamine in one way or another. And these non-motor symptoms, the first four I've listed here, are not due to dopamine deficiency. They're due to different changes in the brain and in the nervous system. Depression and anxiety sometimes does respond to a little bit of improvement in dopamine, but it's only partially. There's other neurochemicals involved. And then to complicate things even further, hallucinations are from too much dopamine in some respect, or so in that case. So I think this is an important thing for patients to understand, because you feel like, well, here's a symptom of Parkinson's disease, I should treat it by taking more Parkinson's medicines. And in some of these instances, taking more dopamine medicines is not going to help. And in some cases, it's going to make things actually worse. So what do we actually do? Well, for constipation, there are some practical things in terms of staying well hydrated, eating lots of fiber. There's some medications that can be used to help with constipation. It is an important thing to keep ahead of for your overall health, and even for the treatment of your Parkinson's disease, because your medicine has to move through your gut to get to the place where it's going to get absorbed into the bloodstream. For low blood pressure, fluids are important there. Getting some more salt in the diet. You hardly ever hear a doctor tell you to eat more salt, but sometimes with our Parkinson's patients, we end up doing that. Exercise can help with that. And there's some medications that can either be withdrawn, or some medications can be added to help with the blood pressure. For this acting out of dreams, this REM behavior disorder, or RBD, the first line therapy is melatonin, which is a very safe agent, a naturally occurring agent, but it really can work for REM behavior disorder. If melatonin doesn't work, the second line therapy is clonazepam. Clonazepam is kind of a respectable cousin of Valium. So the fact that it's a cousin of Valium should give us pause, but the fact that it's a respectable cousin allows us to use it. For cognitive impairment, there are some medications that have been demonstrated to have some beneficial effects in Parkinson's disease. Depression and anxiety, we treat both with antidepressant medicines and with psychotherapy. And then for hallucinations, this is a particularly tricky area because most of the drugs that have been developed for treating hallucinations fall in the category of psychosis. So this category of drugs is called antipsychotics. Most antipsychotic agents, things like Haldol, will make the movement aspect of Parkinson's disease much worse. So if we're going to treat hallucinations with medications, it's a relatively short list of antipsychotics that have the potential to reduce hallucinations without making Parkinson's worse. So I've listed those three here, but again, this is something to be discussed with the doctors and thought about very carefully. Okay, so we're getting late in the hour, but the last thing I think most of the crowd wants to hear, well, what should I do as a patient? What should I do about all this that I'm being advised? The first point that you'll hear from every doctor about Parkinson's disease is that exercise really, really makes a difference. And I know the Brian Grant Foundation is very supportive of this stance as well. And there's different types of exercise, aerobic exercise, meaning like treadmill or stationary bicycle or even more ambitious aerobic exercise, resistance training, meaning weightlifting and that sort of thing, balance training, stretching, all of those are good. When I'm advising my patients, I really push aerobic exercise because I think it captures a lot of different things. So we can also give them a discrete number to aim for. 150 minutes per week is 2.5 hours per week. That's 30 minutes 5 times a week. That's within everybody's reach, but it also is hard to do it unless you really put your mind to it. So having a number and thinking about trying to make it every week is a good way to go. There's lots of great exercise programs in the Portland metro area. And I realize some of my audience is outside of Portland, but you know, the Rocksteady Boxing and the Dance for Parkinson's and ping pong at Pro. And I'm sure there's some things at Brian Grant that I am neglecting to mention, but exercise is the number one thing we should think about. The other thing that exercise is part of is I always remind people that Parkinson's disease isn't happening in a vacuum. You know, the change in those dopamine cells and so on, it's occurring in the milieu of the brain and in the milieu, you know, the environment of the entire body. So taking care of your overall health is really very important. But, you know, for me to say, take care of your health is just a platitude, right? That's not really very concrete. And what I like to point people to is this program that the American Heart Association runs for your overall health. And it's a lay-friendly program. It used to be called Life's Simple 7. Now it's Life's Essential 8. And the 8 factors are don't smoke, keep your weight down, eat appropriately. I'll look them up here. So what did I trying to do in my memory? Healthy eating, fitness, don't smoke, get good quality sleep, control your weight, control your cholesterol, control your blood sugar, control your blood pressure. So when I present this to people, they all kind of roll their eyes and, oh, we already know this, right? We know this is good health habits. But what I emphasize about this is when you look at this website and you look up Life's Essential 8, they give you very specific benchmarks that you should be aiming for in each of these categories. And it's only 2% of the American population that meets those benchmarks. And they're not outrageous benchmarks. They're just standard health benchmarks for each of these things. So I really encourage my patients and even my family members at risk to take this seriously and go to the website. And what you can do is you can click on each of these, and there's great lay-friendly advice on each of them. So if you click on the nutrition one and go deeper and deeper, you can get to the point where you can get recipes, you know, that are healthy for you, that are really quite good. If you click on the fitness and keep looking in great detail, it'll give you walking paths near your home to show you a good place to, you know, get your exercise. So, so that's the second thing for your overall health to really keep in mind. The other thing that I would recommend for everyone with Parkinsonism is, you know, avoid drugs that block dopamine. So I've already mentioned the antipsychotic drugs block dopamine. There are some medications that are billed as antidepressants. They really didn't start out as antidepressants, but some of them are antipsychotic agents that have been repurposed as antidepressants, and they aggravate Parkinsonism, and watching out for them. It's most antidepressants are not in this category, but take a good look at your medicines and make sure you're not on a dopamine blocking medicine. The other category people forget about is that some of the older anti-nausea medicines, so Reglon and Compazine being the ones that were used in the past, are dopamine blocking medicines. That's how they work. So you want to watch out for them. If you get admitted to the hospital, sometimes people write, as needed orders for nausea, and they include some of those medications and fail to recognize that they can worsen Parkinsonism. The other part is, really, you need to partner with your doctor. And as when we were talking about diagnosis in particular, I was telling you about the pillars of medicine, the history and exam. The history, we have to hear the history from you. So we need to know what the symptoms are that are bothering you the most. We need to know which medicines you're taking. I can't tell you how often people come in and they're not quite sure what medicines they're taking. So I can't prescribe something new if I don't know what they're already on. So that's a very important part of partnering with your doctor. And then the other thing that is really quite challenging, and this is something that is a two-way street, but we have to, with more advanced Parkinson's disease, we have to think about prioritizing symptoms. When I have somebody come in with a whole long list of symptoms, I have to figure out which ones we think are the most important, because we can't always treat everything at once. And then my last point, I think, is, you want to really educate yourself about these things. Be careful of the disinformation superhighway. Know what your sources are when you're trying to learn about Parkinson's disease. So this is being sponsored by the Brian Grant Foundation, which is a good source. Parkinson's Resources of Oregon is also a great source. The Parkinson's Foundation is a national, international program, and the American Parkinson's Disease Foundation. So those four, you can really trust the information that you see, but don't believe everything you read out there. There's a lot of stuff that's just bunk. So we took questions as we went along, and Amy, I don't know what we have in terms of time. I'm going to let you manage the time from here on out, and I'll stop sharing.
All right. Yeah, we've got a few more minutes and we've got a few more questions. So going to the non-motor symptoms, should your MDS, your movement disorder specialist, handle the non-motor symptoms? And if not, who should you see?
Yeah, so most movement disorder specialists do handle the non-motor symptoms. Some general neurologists are a little less comfortable handling the non-motor symptoms. And there are some symptoms that, individual, even movement disorder specialists are going to vary in how much they're going to want to take on some of those non-motor symptoms. So between the neurologist and the primary care doctor, you should be able to get referrals as needed. So, for example, if you have a sleep disorder, you could see a sleep specialist. If there's depression, anxiety, impulse control disorder, psychologist, psychiatrist. But I would, if your neurologist, even if they're a movement disorder specialist, is not comfortable handling those things, then I would go back to the primary care doctor and ask for appropriate referrals. Even in our practice here at OHSU, we recognize our role in treating non-motor symptoms, but each of my colleagues probably manages them a different way. Some of us are pretty comfortable with antidepressants, others go to the psychiatrist pretty quickly. Some of us are pretty comfortable with bladder medicines, others go to the urologist quickly. So it varies with the provider.
How insignificant can the symptoms be for REM-based or REM sleep disorder? Is it yelling or is it just acting out? At what level would you diagnose somebody as that?
Yeah. If they're just yelling, I might not be too concerned about it. It's usually acting out, physically acting out the dreams. The definitive diagnosis is with a sleep study. So when people have a sleep study, the sleep specialist can document that you are not paralyzed when you're in REM sleep, and then that documents the diagnosis. Now, I'll also say that even if somebody has relatively minor symptoms, if they're bothersome and they want to be treated, melatonin is a pretty low risk treatment to try. So
Can melatonin have the opposite effect and keep you
I
awake?
haven't seen melatonin keep you awake, but I'm sure somebody's experienced it.
Okay. And then about how long after being on Mirapex can you, let's see, how quickly would you know on Mirapex if there were impulse control symptoms?
You know, uh, it's probably a few months you'd have a sense of whether you're going to get impulse control symptoms
No.
at a given dose. I have had people who have had the sense that they've developed symptoms after a dose increase. So it does seem to be dose related.
Okay.
Yeah.
Well, I know there were a lot of questions we didn't get to, and I just want to end on this last one is what's coming down the pipeline that has you excited, that can give us hope?
Good. I think there are a number of um, treatment strategies that can slow the progression of the disease that I think are pretty promising. The term we use in general is disease modifying therapy, and there are examples of that with harnessing the immune system, with targeting enzymes called kinases, or with turning genes on and off with something called antisense oligomers. And those are all very promising areas. Nothing is at the point where the FDA is going to review it for approval in the near future, but there's late stage clinical trials and all those things. So I think there's reason to be optimistic for a disease modifying therapy. I'll also, point out that when I was in training, there were no disease modifying therapies for multiple sclerosis. And now there's like 20 of them, and it's a completely different world. And I think once you get the first therapy, it snowballs. It really paves the way for other therapies. So I think we're getting close to that with Parkinson's.
Well, wonderful. Dr. Quinn, thank you so much. And there are so many more questions coming in, and I'm sorry that we couldn't get to them, but I appreciate you joining us today. And for everyone else, we will be posting the video of this webcast on our website and in the newsletter to come. So thank you, everybody, and I hope you have a wonderful day.
Thanks, Amy. Thanks for the invitation. Enjoyed it.